I'd love for you to talk a little bit about just examples of how counties partner with health centers and sort of what does this look like?
Community health centers can really be a valuable partner in this space in terms of service provision and also care coordination.
I'd love to hear kind of what you guys are thinking or how you're working together to look for solutions sort of in that direction, at least at this stage. When the federal government cuts Medicaid, counties don't just feel the impact, they carry it. In this episode of Community Health Centers Unfiltered, we're digging into the real-life consequences of the One Big Beautiful Bill Act. I also call it HR 1, and its Medicaid cuts, with a focus on what's left to pick up the pieces. Spoiler, it's often the local government. So what does this mean for community health centers, for counties trying to fund public health programs, and for patients who rely on Medicaid every day? We're breaking it all down with Blaire Bryant. She's the legislative director at the National Association of Counties, or NACo, with insights from the front lines of local government, healthcare, and policy. She's amazing, and I can't wait for this conversation. So let's jump into it. Well, hi, Blaire. I'm Amanda Pears Kelly. I'm the CEO of Advocates for Community Health. I'm so excited to talk to you today because, holy smokes, there is a lot of work going on, and you guys are busy at the county level and trying to, steer the ship. But I would love it if you could just introduce yourself and get us started there.
Absolutely. Hi, Amanda. I'm Blaire. I'm the Legislative Director for Health Policy at NACo. And so I oversee all of our advocacy work in the health space. And at the county level, that's really inclusive of the entirety of the healthcare safety net. So that means hospitals, health centers, as well as local health departments, mental and behavioral health, as well as long-term care. It runs the gamut of the full safety net and making sure that those facilities and the staff have what they need on the federal level.
So I'm going to just get right into it because I think what's on the top of everybody's mind and the tip of everybody's tongue is what's happening with the One Big Beautiful Bill Act, HR 1, and sort of what does that look like at the county level? Like, how does that translate to the work that you're doing?
Absolutely. So as it relates to HR 1, it was kind of a mixed bag for counties, to be honest. So there are many provisions that we are concerned about and we considered to be losses, but there were also some gains. So talking about the gains first, the positive, we did see the nursing home staffing mandate moratorium, which is something that we have been advocates of simply because it provides a little bit more of a runway for local nursing homes to staff up in order to fulfill the staffing requirements that was included in that mandate that came out under the Biden administration. So we were happy to see that. We were also happy to see more flexibility around the home and community-based services waiver option to help us better serve individuals in home and community-based services. So we're happy to see that as well. And then, of course, the $50 billion in rural provider relief funds. We were happy to see some sort of funding that could possibly be used to improve healthcare access in our rural areas. In terms of what we consider to be concerning and losses, obviously we're losing flexibility as it relates to local Medicaid financing, which is a big deal for counties because we partner with states in financing the non-federal share of Medicaid. So things like the provider tax reform in expansion states are concerning to us, as well as changes to state-directed payments. These really reduce the level of flexibility that localities have in order to direct Medicaid funds appropriately and finance the non-federal share. And then, of course, provisions that will lead to large amounts of coverage loss and require heavy fiscal and administrative burden on the county. So this includes the work or community engagement requirements, as well as eligibility verification changes. So these are going to be very burdensome for counties to implement.
Yeah, I think that's I believe, probably unintended consequences of some of this is that it just, operationally, I think a lot of people are still trying to figure out. I was just at the NASHP conference, and by the way, thank you so much for joining us in the middle of a conference yourself. But just coming from that, I think a lot of the conversation was around just the reality of implementation and trying to navigate that, but then also, to your point, the burdens of, okay, this is going to add layers of verification and validation and developing frameworks and all of that. And there are some resources maybe to support that, but a lot of them, it's to be determined. And so
Right.
what does that look like? And I think one thing I'd love for you to speak to is, I'm not sure everybody understands the connection between federal policy and sort of how that comes down to the county level. Like, do you want to can you speak to that a little bit of like, what does the reality of that look like?
Absolutely. So counties are a part of that federal, state, and local partnership that I just mentioned. A lot of people attribute Medicaid administration to just states, but counties and other forms of local government also play a huge role in administering the program and financing the program. So counties in particular, we help finance the program through additional contributions to the non-federal share. In many counties, they are providing funding to go towards that non-federal share, and some counties are even mandated to do so at the state level. So counties are also fiscal contributors, but we also administer the program, and we do it in two ways. So first, we are in some states the lead entity for eligibility verifications. So that means we are doing all of the re-enrollment and verification processes at the county level. And then secondly, we administer Medicaid services through our healthcare safety net. So that's the hospitals, the health centers, the long-term care facilities, and mental health facilities that provide Medicaid eligible services. So counties play a huge role in running the program and contributing fiscally. So anything that happens in a partnership that is federal, state, and local will impact counties. So it's a delicate dance that we do. If the federal government does not provide or pulls back on their share, that means the state and the counties will have to put more into the pot in order to keep the program running. So any changes like what we saw in HR 1 are going to impact county budgets as well as state budgets.
Yeah, I appreciate the way you just framed that as sort of like, okay, well, if you just think of it as like a balance, it's sort of like if one side comes up, the other one has to, it just, you're always having to make it up to find that balance. But a lot of that looks like the state and the county and the local level figuring that out. So we're in an interesting time right now, for sure. But I'd love for you, to that end, and I think especially, you were speaking to eligibility and verification and all of that, but I think even more broadly than that, I'd love for you to talk a little bit about just examples of how counties partner with health centers and sort of what does this look like? And through that lens of HR 1, like, are there things that you guys are anticipating or looking to health centers to say, okay, how are we going to do this together? Just because obviously there's a long history of work together and partnership and just, all of the stakeholders that you've mentioned. But I'd love if you could speak to that, just in sort of models that you've already seen that have worked really well or underway now, but then also just sort of thinking forward, like, what does that look like and how can health centers take a proactive role in trying to be supportive and engaging?
Absolutely. So the most common model that we see in terms of health center partnerships with counties is kind of the hub and spoke model that we see in rural counties. So we know that rural counties don't have hospitals every 5 miles as it would be in an urban county. So, and a lot of times their hospitals have kind of the bare minimum of services just based on tight operating margins. So health centers help to fill the gaps in terms of primary care and other services in rural communities in particular. So that is the biggest and best partnership that rural counties and community health centers have with one another, is that hub and spoke model where the county hospital is the hub and then the community health center or federally qualified health center acts as the spoke. Another way that we see community health centers kind of filling in the gaps and lending a hand to county services is through reentry. So actually SAMHSA just recently, I think last year, released guidance on how community health centers can help with reentry services, meaning getting individuals who have been recently incarcerated and are being released connected back to care and being that warm handoff entity. So we've seen that community health centers are already playing this role in communities. In some communities, if they're not providing that warm handoff, they're also helping to cover the gap in terms of services that are actually provided in the jail. So that partnership with jails is super critical and another important way that community health centers are partnering with county services.
I love that. I mean, it's an interesting one, right? In some ways, it's really obvious just because it's sort of like, okay, to your point, like when you're talking reentry, like healthcare and access to healthcare is one of the most important components of what that looks like, whether it be medical, dental, or behavioral health. So I love to hear that, but I also really appreciate that that from a county perspective, that health centers are sort of top of mind in terms of what that can look like and how to construct that. I'd love for you to speak a little bit more. I know we were chatting a little bit earlier about the behavioral health component. I know you're in a space right now where this is, there's right in your midst, there's another really great model. Do you want to speak to that a little bit?
Absolutely. So another thing that, another way that community health centers can partner with the county is through interdisciplinary teams and care coordination. So right now I'm in Henrico County, Virginia, and we are learning all about the various ways in which this county is coordinating crisis services, substance use disorder services, and behavioral health services broadly. And the primary way in which they're doing this is through interdisciplinary teams. Either interdisciplinary justice teams, interdisciplinary healthcare teams that help on the crisis front, as well as the substance use disorder front, and then also interdisciplinary youth mental health teams as well. So community health centers can really be a valuable partner in this space in terms of service provision and also care coordination. So working with county services like the county mental health services, the county jail, on their diversion teams, on their youth mental health task force, and in their crisis response efforts could be another critical way that community health centers partner with counties and make sure that you're all aligned on care coordination.
Yeah, I love that. And that, I mean, I feel like we're speaking the same language just in terms of care coordination and integration. In an interesting way, it kind of brings me back to conversations about the One Big Beautiful Bill Act and HR 1 and just sort of what does it look like in terms of how you guys are anticipating how resources may be dialed back for safety net providers and just sort of like, what does that look like? And I mean, I know there's still things to be determined, but would love for you to speak to that a little bit.
Yeah, absolutely. So the biggest challenge that we foresee with some of the reforms that were included in HR 1 are the impacts on uncompensated care. So we'll likely see, as has been predicted by many research agencies as well as CBO, we'll likely see a loss of coverage because of some of the provisions included. So a loss of coverage on the healthcare safety net looks like uncompensated care. An individual who comes into a health facility, whether it's a hospital, an emergency department, or even a health center without adequate insurance. And so what happens to that person? What happens to the bill that they incur when they come in seeking services? Well, counties are the payers of last resort. So that means that we typically rely on that county, that individual's insurance to take care of their care. But if there's no insurance to step in and provide payment for the services rendered, then the county is responsible. And the county could be, in that instance, the hospital, the health center, the long-term care facility. So whatever county facility that that individual walks into will be responsible for the payment of the services rendered. So that means that we'll see a large increase in charity care or uncompensated care across many of our health safety net facilities. We're particularly worried about hospitals and specifically worried about rural hospitals who, as I mentioned earlier, are already operating on tight margins. And so an increase in charity care for that hospital could be hiring freeze, or it could be even closures in extreme situations. So that impact is going to be acutely felt by our local health safety net.
Yeah, and it's much the same for health centers, as you know. I think, the national average, most health centers are operating on a 1% to 2% margin, if that. Some of them, many, unfortunately, are in the red. But to your point, it's sort of for health centers, as you know, they have to see everyone regardless of their ability to pay. And so, what it looks like is the potential for many, many patients to go from being in coverage to uninsured without any additional resources to be able to cover the cost of that care. And so, just to your point, what it looks like is really tough decisions. Whether it's dialing back services or having to do reduction in force, having to close sites, and in some cases closing doors entirely, which is obviously not what we want to see in a worst case scenario. But I guess, you know, with that in mind, are there things that you guys, this is a little bit kind of off script, but are there things that you guys are doing in anticipation of that to try to figure out how to absorb those things or how to prepare for it? Or, you know, I think a lot of this, and you and I were chatting about this earlier, it's really hard to predict. You know, we don't know, and it's still in the distance, and there's still guidance coming. And so some of these things will help inform and shape sort of how all of us work together to make sure that we can make this as successful as possible. Because I do think that there's commitment to that. It's sort of, this is what's happening, this is the law, here we go, let's make sure that we can meet mission, which is making sure that people have continued access to care no matter what. But I think also to make sure that we set up the procedures and the frameworks to be able to minimize the barriers to being able to do that. So if you're able, I'd love to hear kind of what you guys are thinking or how you're working together to look for solutions sort of in that direction, at least at this stage.
Absolutely. So I'll answer the first part of your question, which is kind of what are counties doing right now in order to prepare for the projected impacts of HR 1. And then the second part of your question is what are we advocating for in terms of solutions, which is kind of in a different shop. But right now, in terms of what are counties doing to prepare for anticipated impacts, like you said, it's more of a brace yourself and try to estimate what the impact will be based on the numbers that we already have. The issue here is that a lot of the impact is going to come down from the state level. The state will have ultimate say in terms of services that will be cut, operating budgets, or any sort of reduction in funding at that level, which will trickle down to the county level. But some of our counties, particularly our large urban counties, can already start to estimate and make plans for the type of reductions that they'll see in federal funding, and then make decisions based on what they know will happen. So one good example is Cook County, Illinois. So they're facing a 19% cut to Medicaid funding, the state of Illinois is. And they're projecting about a $222 million loss in fiscal year 2028. That's on the county safety net hospital, Cook County Health. They're projecting that loss. So one thing they've already done to kind of mitigate the loss that they'll experience is a hiring freeze. So they've put a freeze on any new hires for the healthcare system in its entirety. That's going to impact services. It's going to impact wait times. But right now, it's what they can do to try to mitigate some of the losses that they know they'll incur in the coming fiscal year. So counties that have the ability to estimate their loss down to the dollar level can start making early decisions to try to mitigate those losses. Some counties don't have that ability to fully estimate and appreciate the loss that they have. So what they have started doing is working with their states and trying to get ahead of any sort of service reductions and funding cuts that will trickle down. NACo has been partnering with the National Council for state legislators to try and make sure we're connecting county officials with their state legislators so they can stay a part of the conversation and mitigate any additional harm to county health systems that may come because of decisions to cut services and additional funding. The second part of your question, which is what are we advocating for to help mitigate some of the challenges we know will come as a result of the legislation? Well, first is making sure counties are aware of the additional resources that they have to implement some of the provisions included in the bill. The biggest opportunity right now is the Rural Health Transformation Grant Program. So right now we're making sure that counties are aware of the funding that's out there. Although the funding will be awarded to the state, wanting to make sure that the state is partnering with the county to kind of get an assessment of what they would need in order to continue services in rural communities and improve healthcare access, and then making sure that counties have a seat at the table so when the funding comes, they're able to get a portion of that funding. So making sure counties have adequate resources, making sure they're aware of deadlines, and then also capitalizing on legislative and regulatory opportunities that are being afforded to us right now. which include existing opportunities through 1115 waiver authority. So we talked a little bit about reentry before. We still have an opportunity to improve access to care through the reentry waivers. And so making sure that counties are continuing to work with their states to implement these waivers, especially those states that have approved waivers. And same thing on the substance use and serious mental illness side with regards to 1115 waivers in that space. Those are still opportunities to increase access to care. And then lastly, I'll say what we are working with counties on and what we're hearing from counties in terms of getting ahead of some of the impacts is assessing what can be done below the federal level. So think little p policy to get people connected to care, particularly looking at value-based payments reforms and payment models to maximize the remaining amount of Medicaid dollars that they have. And then also upstream solutions for building economic mobility for our residents so they can qualify for commercial insurance and getting access to care that way.
Got it. Well, so listening to that, and it's super helpful. Thank you. It strikes me, and there's two pieces to this one too, typical from me, but one, it differs enormously from state to state and how the county interacts with all of these things. I know just from having members in California, like the role of the county and the policies that the county is rolling out versus what's coming down from the state is quite different than, we'll say, Texas or Tennessee.
Right.
And so I'd love to hear sort of like, okay, from a policy advocacy perspective for folks that are listening, like what's the best way to engage and sort of help and be involved on the advocacy front, but then also just in terms of operationally, like what does this look like and how does it get rolled out? But then the other question, and maybe this is the first part, is what does this look like from county to county in terms of how you would categorize counties differently? So like, is there a disproportional impact, whether it's rural or underserved or urban? I'd love to hear you speak to that, because my impression is that there is a disproportionate impact, but I would rather hear it from the expert. I don't want to make the assumption. So can you speak to that a little bit?
Yeah, I think that when we think about our healthcare safety net in general, there'll be a disproportionate impact on rural communities with regards to impacts to the healthcare safety net. So the full spectrum of services and care at the local level. So rural communities already kind of started at a disadvantage because they had less resources in their safety net. So less hospitals, if they had one particular hospital per county. Sometimes counties share like a regional hospital, and that county may already be operating on tight margins as we specified. So rural counties are going to be disproportionately impacted in terms of the effects of less Medicaid dollars coming into the safety net system and even less money to operate off of. So, and then those counties also happen to be, or those communities happen to serve disproportionately more Medicaid patients. So when individuals are disenrolled from Medicaid, that means that the rates of uncompensated care will be higher in those communities. So that's a disproportionate impact on healthcare safety net and the services. I think urban communities, particularly those urban communities that have expanded Medicaid, are going to see a disproportionate impact on the amount of Medicaid dollars that have been lost. So when I mentioned Cook County losing $222 million, that's a disproportionate impact. You'll probably see a lower number in a smaller community in terms of loss of federal Medicaid dollars, but larger communities, because they have more people enrolled on their Medicaid program and more potential for coverage loss, are going to see a larger amount of dollars that are now lost in terms of federal funding. So the impacts are going to vary in terms of the communities. Urban communities will have one impact and rural communities will have another. But I think that there will be a widespread impact on every county and then down to the resident level as well. So The residents that are seeking care will have less options because we're looking at the changes to HR1 in a continuum, right? So not only is it Medicaid reforms, but it's also changes to the Affordable Care Marketplace. So if you can't be on Medicaid or don't qualify for Medicaid any longer, you can't as easily get access to care through the marketplace. And so in some cases, what you're seeing is an individual who can't get insurance anywhere, and that's an impact on their ability to seek and receive healthcare services. So what we'll see across the board is increased reliance on hospital emergency rooms as well as our jails for the provision of care. And that's going to be kind of universally because people will lose access to healthcare coverage.
Yeah, the hardest thing. I was just going to say the hardest thing about that, right, is that that's among the most expensive forms of care. And so it's
exactly,
I think that
the most expensive and inappropriate forms of care.
Yeah, I think that's what, makes my heart race, is just sort of like, okay, I see where we're going and I see the intent, but I'm not sure we've connected the dots yet on what the long-term kind of outcome is going to be. I think that there are predictions, but we'll cross that bridge as we need to, so to speak. But I also really appreciate hearing what you're saying. Like, it's remarkably similar in terms of what this looks like for health centers. And part of that is 50% of health center patients or just over 50% of health center patients, now 32.5 million people, are covered by Medicaid. And so same thing, it's sort of between the losses on Medicaid reimbursement as patients come off of coverage, but then also, like we said before, having to continue to provide that care, it just sort of shifts into the uninsured category. I'm curious. I know that there are some models, and again, this is sort of, I'm taking us all over the place in terms of the conversation today, but I know there are some counties and some places where there are state and county funds to help health centers to be able to support sliding fee, and in instances like this. But I also realize that resources are scarce in every level, in every corner. And so, but has that been part of the conversation? I mean, part of my reason for asking is that's the reality that health centers will face, much like the county hospitals and sort of other elements of the safety net. But I think the other thing is, when we think about where the greatest savings come from, in terms of continuous care, integrated care, managing chronic conditions, all of that, health centers are really one of the best investments, and we know that it saves the system money. So is that part of the conversation at all, or are there models that exist in terms of whatever resources do exist to put into health centers? And is this a time where that's sort of on the table, that whatever resources exist, maybe this is the place to go? And just would love to hear your thoughts on that.
Absolutely. So this really speaks to what I was talking about earlier with regards to those interdisciplinary teams, and then those multi-sectoral disciplinary teams for addressing care coordination at the local level. So because we know that health centers are kind of a model that work in terms of healthcare savings and then improving access to care, that's why having them a part of a multidisciplinary team to improve care coordination could be super effective. So particularly for hospitals that may have to close down a wing of their hospital and not provide certain services because of the tighter operating margins, they will have the option to say, what services can we push out to our community health center? And so that's something that can be decided in one of those interdisciplinary teams. This is why partnerships are hugely important right now as we start thinking about implementing HR1 and implementing some of those Medicaid reform provisions. Community health centers partnering with county officials as they think through, how do we still offer the same level of services without having to pay more, essentially? How do we continue to do what we've always done with less resources? So those partnerships right now and community health centers not working in a silo will be hugely helpful in terms of implementing these provisions.
Yeah, so what I take away from that is, if, I'm thinking of all of our health center members and frankly, just the network of health centers as a whole. And I know our state primary care associations are phenomenal, but I think there's just been so much going on. But I think what I take away from that is, if there hasn't been a conversation with the county or maybe there have been conversations, but specifically about what you're talking about in terms of the partnership, like now is the time, as things are being designed and considered and so forth. But I'm thinking about time, and I guess I love this question because we're in an interesting moment, and obviously there's a storm underway, but not only will we get through it, I also think things can be better. But like, if you had the magic wand, like if you could design something that sort of serves the needs of counties and that wider safety net and sort of everyone working together, like, can you just talk through, like, what does that look like? And taking out of, the equation, because we're using a magic wand, the limitation of resources, and sort of like, I truly mean it. Like, if you could design the policy, and you have such incredible experience, I know you've been doing this for a really long time, but from your perspective, like, what does that look like? What is the perfect scenario, and sort of how would that exist?
Well, this would be very idealistic, as there is no real perfect scenario, because one thing that we say at NACo is if you've seen one county, you've seen one county. So what may work in one county may not work for another county, just based on resources and how their counties are set up in terms of the services and how they're organized. So just have to caveat that. I know this is Blaire's dream, but also just have to caveat that counties vary in terms of the types of services that they provide and how they provide them. But if I had to idealistically say, how could the system work in terms of effectiveness, it would be that all of our healthcare safety net entities, so think about it as like a little town where you have here the hospital, you have the long-term care facility, you have the mental health facility, all owned and operated, and the county fiscally contributing to it, kind of get together, and we're talking about how to move individuals, residents in our communities, through each safety net entity in a way that maximizes their service provision and then also maximizes the resources of the county. So if what they need is actually mental health services, then it's not effective to go to the jail. And so how do we prevent that person from going to the jail and getting care where they need it? That's the best use of our resources. Many counties are already doing this. They have, like I said, those teams that are thinking about this in a forward-looking way, but maybe not as comprehensively to include the hospital and the community health center as a part of that plan. So in my idealistic dream world, every entity, whether it be health, mental health, or even justice, would come together to improve care coordination and maximize resources.
I really love that, honestly. And you're right. I know it does exist, and it's different. You're 100% right. We say the same thing in the health center world, where it's, you see one health center, you've seen one health center. But what I love about that, Blaire, is that it's this incredible, not even patchwork. I think it's just an incredible kind of quilt of all of the services and the stakeholders and the partners all working together to achieve the greatest possible outcome for the residents, or in our case, obviously on our side, it would be patients. But because all of these resources and services exist, it's just a matter of, like, are they all connected in order to maximize the best possible outcome? So I love that. And right. I think, you have health centers who are already partnering in that way, but I think you have many, many more who would get in line to be able to do that. So I would be excited to continue the conversation in the future around how do we do it? How do we design it and sort of elevate that as a North Star, and sort of how we can work together as partners.
Yeah, and I think that's a role that we fill in as national stakeholders and association. We can speak on behalf of these systems at the local level and make sure, one, the federal government is aware that great work is being done at the local level to improve healthcare access. And once we elevate those stories and elevate the examples of great work happening at the local level, we can get federal buy-in and support for some of these initiatives. And then likewise at the state level, making sure that the state is bought into what's happening at the county level, at the health center level, so that they can be producing and giving resources that support that, as opposed to moving from a top-down approach, which limits the flexibility that we as locals have to do great work.
No, I'm so glad you said that, because I think that's actually, from a grassroots perspective, we talk about that a lot, that it's sort of, there's so many different levels of influence and and impact, and it starts local and county and state and federal. Like, you have to touch all of them. They all have to be synced up together. So I'm really glad that you bring that up, because I think way too often it tends to be lopsided. It's sort of very top heavy, or maybe it's so locally focused that it doesn't translate. But I think the sweet spot and the best case scenario is when you have all of the stakeholders working together. But I'm so grateful to be able to talk with you, and I'm so appreciative of the work that you guys are doing. And there is certainly a lot of work to do, so I imagine this is the first of probably many conversations. But just thank you so much for joining us today, and just know that health centers are always poised to step up and to work and be partners with you guys, and we're very grateful.
Thank you, Amanda. Thank you for the opportunity, and thank you for the continued partnership with counties.
So that's a wrap on today's episode. Huge thanks to our guests for breaking down the ripple effects of Medicaid cuts and what they really mean for counties, community health centers, and the people who they serve. If you're concerned, you're not alone. Obviously, this is our work, but it's yours too. And now is the time to speak up, team up, and push for smarter policies that don't leave local governments and safety net providers holding the bag. So don't forget to subscribe, leave a review, and share this episode with your networks, especially anyone who works in local health policy, community leadership, at the health center, you name it. We all need to work together to get this done. I'm Amanda Pears Kelly. I so appreciate you tuning in for Community Health Centers Unfiltered, and I hope to see you again next time.